Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello everyone, and welcome to episode number 95 of the Better Health Guy blogcast series. Today's guest is Dr. Diana Driscoll, and the topic of the show is Driscoll Theory. Dr. Diana Driscoll is an optometrist who became passionate about helping those with complex health conditions as a result of her own health challenges with POTS, Ehlers-Danlos Syndrome, and ME/CFS. Today, she is recovered, as are her two children, and is the clinical director of POTS Care in Colleyville, Texas. She is president of Genetic Disease Investigators, LLC. Her husband, Richard, is also a doctor, and together they have worked to find answers to POTS using unique ocular testing. They are intimately familiar with POTS, chronic fatigue, brain fog, immune system decline, gastroparesis, temperature dysregulation, interstitial cystitis, and more. She offers hope for those dealing with POTS, dysautonomia, Ehlers-Danlos Syndrome, mast cell activation syndrome, chronic fatigue, chronic Lyme disease, vascular abnormalities, fibromyalgia, and multiple sclerosis. She is the author of The Driscoll Theory, The Cause of POTS in Ehlers-Danlos Syndrome and How to Reverse the Process. From her personal and family journey and her work with patients, she's created a line of supplements, including the patented ParaSym Plus, to meet the specific needs of those dealing with these complex chronic illnesses. And now, my interview with Dr. Diana Driscoll. The topic of POTS, or Postural orthostatic tachycardia syndrome, dysautonomia, Ehlers-Danlos syndrome, and the vagus nerve are topics that I've been wanting to do a show on for some time now. Today we have Dr. Diana Driscoll on the show to share her personal journey of hope and recovery with us and help us connect the dots with some of these complex topics. Thanks so much for being here, Dr. Driscoll.
Thank you for having me, Scott. It's really an honor.
Tell us about your own personal health journey. How did it start? What was the trigger? What were some of your symptoms? And were your symptoms more orthostatic, as many think about with POTS, or did the condition have a systemic impact?
You know, my health journey wasn't unlike yours, Scott, in that it was miserable and it was so long, it was frustrating to find answers. In fact, I was on disability for over 10 years before getting the full picture. It all began when I went on a mission trip to Costa Rica and got a virus. But you should know that every one of us on the trip got the same virus and everyone recovered, except for me. Even 2 weeks after returning home, I started to notice weird things happening, like I seemed to have to remind myself to breathe. Who forgets to breathe, right? My heart rate began to go up. If I stood up or even leaned forward while sitting, my heart rate went up. Sometimes when I ate, the food just sat in my stomach for hours at a time. I developed a tremor worse on my right side. I had difficulty sleeping early on, would sometimes wake up gasping with my heart racing. I felt hot, sort of panicky. I was completely disabled rather immediately. In fact, I couldn't see my last two patients the day I was hit. And I could push through a lot. I couldn't push through. So, of course, I went to the doctor. In fact, we ended up seeing about 50 doctors my first 3 years of illness. And as we did so, my symptoms were changing and evolving. I remember before a doctor's appointment, I'd pull up my list of symptoms for them and I'd have to update them. It was like chasing a moving target, which was frustrating for both me and the doctors, honestly. But initially in the illness, I had these episodes, for lack of a better word, that caused an almost pseudo-seizure type presentation. I felt hot, panically. I couldn't breathe. I had rather violent tremors. My heart rate jumped up. I couldn't handle any change in temperature. And these lasted from about 20 minutes to about an hour. Nothing helped. I sometimes found myself on the floor on all fours trying to breathe. And when they passed, I was weak, shaky, cold. I was often bedridden for a couple days after. But between the episodes, I had some normalcy for a while. I worked out. almost every day, because at the time they were saying the exercise helped POTS, right? But later, if I worked out even for 5 minutes, I was in bed for 2 days. But over time, the episodes became less dramatic, but my normalcy between them disappeared. And at that point, I was just basically sick all the time. Yet the illness continued to evolve. And at some of the lowest points, I was awake maybe 3 hours a day. And during those 3 hours, I wanted to be asleep. But even scarier, it was getting worse every day. It was far beyond what you would call fatigue. Sometimes I just couldn't move, or I couldn't stay awake. And then about that time, I started to lose my cognitive abilities. I had zero short-term memory, and I developed gastroparesis. My kidneys were failing for 3 years. I had left ventricular diastolic dysfunction, a heart problem. My personality began to change, and it was not for the better. I had about 80 symptoms at a time, and they were constantly changing. So for me, POTS was way more than orthostatic tachycardia. And if that was all it was, I should have been able to sit down and feel okay, right? That's certainly what my doctors thought. But I was miserable in any position. So Mayo diagnosed me with hyperadrenergic POTS. I was basically flooded with norepinephrine. Think of it like adrenaline. I became an insomniac. I was shaking with adrenaline and felt like I could have jumped out of my skin if someone touched me. It was a horrible feeling to feel so sick, yet I got no relief by going to bed or curling up to sleep. In fact, if anything, night times were worse. And yet the doctor's final conclusion after 3 years of participating in clinical trials was that POTS patients, including me, were perfectly normal. We were just more aware of our own bodily functions. It was horrifying.
Wow. Another interesting part of your story is that you had a son and a daughter that both also developed POTS. So I had not previously heard of POTS being an issue within a family. And so I'm curious, is there a genetic predisposition to POTS? What were some of the commonalities in your condition and your children in terms of the triggers that might have initiated that POTS condition?
Yeah, isn't that interesting, Scott? See, I was 46 years old when I developed POTS. But about a year and a half into it, my son, he was 8 years old, got a series of 3 regular viruses, the ones that everyone at school got. But for him, each one made him feel worse. And then the third one just left him completely disabled. This poor guy would sometimes faint just sitting up. See, I never fainted. We tried to keep him in school for about a year or so, but he became too sick even to be tutored. Not unlike me, he was ill, and he felt ill in any position. It wasn't just a positional problem, but even more frightening, then he began to just waste away. When he was 12 years old, we took shorts that he had when he was 8, and we were rolling up the waistband and pinning them on him. He developed severe osteoporosis. He broke his arm throwing a ball once, and once he broke his arm just putting on his jacket, and he was miserable. Now, my daughter also had POTS, but we never could point to a trigger of any sort. We noticed she was starting to show more anxiety and depression and some subtle signs that made us perform a poor man's tilt table test. We tried to have her stand up, see how she did, and she showed she had POTS. She was so much more functional than my son and I. She could stay in school, for example. She never fainted. She wasn't hyperadrenergic like me. We all presented differently. But at the time, I thought, this can't be a coincidence. There has to be a genetic issue, right? My husband was fine. It wasn't the environment. So after I got nowhere with my doctors, nor the Mayo Clinic, I set up genetic disease investigators. I really wanted to find the genes responsible, and that's where our work is today.
Excellent. So let's step back then. Talk to us a little bit about what is POTS? How common do we think it is in the chronic illness population? What are some of the diagnostic criteria? And what might clue someone into potentially wanting to explore POTS?
What a great question, because I don't think anyone really knows how common POTS is, because patients aren't usually tested for it. I mean, how often do you go to the doctor with some of these weird complaints and they say, tell you what, Scott, let's have you stand up for a few minutes and see what happens. They almost never do that. And the criteria for diagnosis is completely arbitrary, which doesn't help matters. The current criteria are if the heart rate increases by 30 beats per minute after 10 minutes on a tilt table test, or 40 beats per minute for children, they make a diagnosis of POTS. And the tilt table test is the gold standard, which is a flat table that takes out the role of the leg muscles, returning blood to the heart, basically. We can sometimes figure it out with what we call a poor man's tilt table test. It's where you have the patient lying down for a few minutes, or sometimes sitting down and then watching for an increase in heart rate when they stand. But my question is this: if the heart rate goes up, say, 29 beats per minute on a tilt table test, does that mean the patient doesn't have POTS? And what about 28? You get where I'm going with this, 27. Where and why do you draw the line? It's completely arbitrary. Shouldn't we instead be looking for patterns of illness, including the orthostatic problems? And POTS isn't a disease, right? It's a symptom. Arbitrary criteria for diagnosis isn't very helpful, but it's what we have today.
So it sounds like POTS, similar to many other things, it's a spectrum of its own, and people can have mild presentations of POTS-related symptoms, or they can be very severely impacted.
Absolutely.
We talked a little bit about the fact that symptoms can go beyond the orthostatic symptoms. So what are some of the more common, broader symptoms that people dealing with POTS, or the systemic symptoms they may be dealing with? And do you then think that those symptoms are the result of POTS itself, or are they the result of the underlying trigger that might have also triggered POTS, but maybe also triggered other systemic manifestations?
That is a great question, Scott. By definition, POTS should mean that all symptoms should revolve around a fast heart rate and perhaps involve some abdominal discomfort if some of the blood is pooling there. In fact, I saw a YouTube video recently with a POTS expert saying that some people with POTS can get a little dizzy and they can get, and I quote, a little tummy ache. I thought, oh my gosh, if this is what they think POTS patients are going through, no wonder they think we're just more aware of our bodies. No, it was completely disabling for me as it was for my son. Our symptoms involve so much more than a fast heart rate or being dizzy upon standing, and I think that's pretty typical. I often told the doctors that my fast heart rate was the least of my problems. Could they please ignore it and look at everything else? Nope, not once you get a diagnosis of POTS. So I don't think there are actually two POTS patients who exhibit in exactly the same way. But there's some commonalities that allow us to get to the same place in our illness. So many of us suffer with symptoms like dizziness, certainly nausea, every GI problem known to man, insomnia, sleep disturbances, pain of many types, poor temperature regulation, mood changes, cognitive problems, brain fog, and many weird neurological symptoms. What I've seen at POTS Care is that more dominants tend to fall over time, changing the symptoms to some degree and often worsening the patients over time. Someone who has had POTS for years may not present in the way they first did when they got sick. So it does evolve.
My understanding is that some conventional practitioners, they may explore POTS triggers, maybe autoimmune triggers, neurological issues, metastatic causes, but that oftentimes POTS is more idiopathic, where the specific cause is not necessarily identified. So if someone has not found the root cause of their POTS or the trigger, what are some of the factors that you found that are important to explore further?
Right. That's a great point, because when you're first diagnosed with POTS, Scott, you have to be sure it's not from some sinister neurological problem like ALS, Parkinson's, Huntington's, for example, and some metastatic conditions you mentioned, such as neuroendocrine tumors, can cause a similar presentation, spinal cord damage, autoimmune autonomic gangliopathy. Although rare, these things should never be missed, but only when they're ruled out do we move to the much more common idiopathic POTS. And at POTS Care, we begin with a list of over 30 conditions that can contribute to POTS. To put the entire picture together, we need to look at a minimum: autoimmunity, intracranial pressure, hypermobility, many forms of inflammation, problems with the immune system, and others. Ultimately, of course, I'm interested in the genes that make us susceptible to POTS. And then if we can locate the genes, that allow us the credibility we need for our suffering too. And of course, offer proper treatment.
And are we close to identifying some of those potential gene contributors?
Yes, we are.
I'm excited. We'll have
Yes,
to have you back at some point in the future to talk about
awesome. That would be great.
So the term dysautonomia refers to dysregulation or dysfunction in the autonomic nervous system. POTS is one of those dysautonomias.
Right.
What are some other conditions that are also considered dysautonomias? And do the triggers for POTS then overlap with triggers of other dysautonomias that are not POTS related? Or are they entirely separate from one another?
Yeah, I do think they're separate. When I first got sick, I went through 2 huge textbooks on dysautonomia looking for my own case. I couldn't find my presentation in there. There are many causes of dysautonomia, but they have different underlying causes from idiopathic POTS. They've got to be separated from the group, identified and treated appropriately. As I mentioned, such things as ALS or Parkinson's, et cetera, can present similarly in the beginning. And doctors understand those conditions fairly well, and they can ultimately identify them. But the idiopathic POTS patients are a puzzle to them. These are entirely separate, likely with distinct triggers and separate treatments. Hugely important.
Yeah, that makes a lot of sense.
Mm-hmm.
What role might POTS play in chronic fatigue syndrome, CFSME? How are these conditions different? And what's the overlap between chronic fatigue, fibromyalgia, maybe chronic Lyme disease, and related conditions with POTS?
Well, I think we're still all figuring that out. I see chronic fatigue, ME, as a big group with most, but not all, CFS patients as having POTS. But if an idiopathic POTS patient is sick long enough, they always develop chronic fatigue. Now, fibromyalgia, of course, is a non-specific diagnosis. It oftentimes overlaps with POTS. Lyme can sometimes be a trigger for idiopathic POTS, as can many viruses, in my own case, some bacterial infections, physical, emotional trauma can also be triggers and eventually cause chronic fatigue. The syndromes have a fair amount of overlap.
Yeah, that makes a lot of sense to me as well. I think chronic infections, environmental toxicity, a lot of these things manifest in different ways. And then we've created these umbrella terms like chronic fatigue or chronic Lyme or fibromyalgia. But I think there's probably more overlap than dissimilarity. I think there really
I agree.
Yeah. And so we just, I think we need to get to, and this is where your work is really exciting, we need to get to what are those underlying causes? What's triggering these things? If someone has MS, for example, well, what exactly is the trigger? MS maybe is a label for specific symptoms or specific findings on, let's say, an imaging study, but it doesn't necessarily tell you what caused that. And so I'm really interested in what's the similarity here between these things. And it sounds like you are seeing a lot of similarities as well.
Yes, absolutely. Completely agree.
So in POTS, there is this abnormal response to an initiating trigger. So in your case, you had a virus, your body responded very differently than all the other people that had the virus on your trip. Should treatment for POTS focus on this abnormal response, or should it focus on the underlying trigger, or should it focus on both? And maybe in some cases, the underlying trigger could already be gone potentially, right? And you may still have the condition. So where should the focus be?
That is important. I think for many patients, we can point to a trigger, like my son and I, but for some we can't, like my daughter. I'm always interested in the trigger, especially if the trigger was physical trauma, because you don't want to miss any physical damage. But we need to consider, why did this person not recover properly while others did just fine? What's different about them? Then ultimately, what else did that problem cause, and what problem did that new problem cause, et cetera? It's the proverbial dominoes falling. If we're going to get the best recovery possible, we have to try to identify all of those dominoes and not just treat it from the initiating trigger. Does that make sense? My virus, for example, had long gone. Everyone else who got the same virus recovered just fine. So why was I so special? If we had treated this as if the virus was still a problem, I would have continued my decline without answers. I think there's often too much focus on the trigger and not on the effects of the trigger, as you had mentioned. And again, one tricky part of this is that we are all potentially different. Every case is a big puzzle, honestly.
And I think part of the reason that you were so special is because your experience now is helping lots of other people. And so while it's not something that we necessarily wanted to go through,
Right.
you look at how much then you're able to impact other people going through something similar. And I think that's very meaningful and purposeful.
Well,
So
thank you. And ditto for you, Scott. Yeah.
thanks. So let's talk a little about Ehlers-Danlos syndrome. And we're not going to get into great detail today, but that is a topic that I've heard come up more and more in the past couple of years in the chronic Lyme community, in the mold illness community. What is Ehlers-Danlos syndrome, and what role specifically did it play in your own journey? And then is there a connection between Ehlers-Danlos syndrome and POTS?
Yeah, I think we need to be very precise when we're trying to figure out the involvement of EDS, Ehlers-Danlos syndrome. And we want to be careful. Is EDS a cause of POTS, or is EDS associated with POTS? As they say, association doesn't prove causation, and it can lead us astray in our thinking. So currently the diagnosis of hypermobile EDS, where the majority of the patients fall, is a clinical diagnosis. Most genes for hypermobile EDS aren't known. So it's based basically on presentation. Part of the criteria for diagnosis assumes the doctor will rule out every other cause of hypermobility. But in practice, it's not really the case. So it tends to lump everyone with hypermobility together in one group, which I think is a mistake. EDS is considered to be a genetic defect of connective tissue, or more specifically, a defect of collagen. Until we identify the genes, though, the term joint hypermobility syndrome might be more accurate, because if we assume a patient has genetic EDS, so to speak, then patients are often told their condition is genetic, therefore nothing can be done. They're just left to suffer. But we need to consider the possibility that the patient has a gene for something that could weaken their connective tissue. This could have a treatable component to it. When I was first diagnosed, I was very hypermobile, and I was told that my POTS was due to a gradual laxity of vessels over time due to EDS. I told them, that sounds right at first blush, but I was 46 when I became ill. My son was 8, and both of us developed POTS mere weeks after contracting viruses. There wasn't anything gradual about it. And as I learned more about collagen, I learned that collagen in the vessels is different than collagen elsewhere. If I didn't have vascular EDS, which I didn't, why would my vessels be affected? And at that point, nothing made any sense to me anymore. In my case, the diagnosis of EDS was basically dead end. Even worse, when my doctor saw that diagnosis, they were afraid of me, and they wanted me to see a specialist. When I asked them, just ignore that diagnosis, can you just treat what you see? They couldn't do it. It was really frustrating, Scott. Now, we're working on finding the genes, of course, involved in POTS, which then overlaps to hypermobility. I think that will be the best way to make any sense of the whole picture. I think we are relying too much on a non-specific label again. It's got to be better defined.
And as I understand, your Ehlers-Danlos symptoms have also improved.
Yes.
So even if there is a genetic component, it sounds like that gene can be epigenetically influenced through a number of different things, so that it's not necessarily always expressing. If it was truly genetic and couldn't be influenced in terms of its expression, then we wouldn't necessarily expect people to be able to get past it, right?
Right. It shouldn't change, right? And that was a real puzzle to the geneticists who worked with me. They said, well, that shouldn't happen. You must have always been this hypermobile, and I hadn't been. They just couldn't really think it through. So
let's talk a little bit on mast cell activation syndrome. So how does that fit into our discussion on POTS? I know in the Lyme and mold arena, more and more people are recognizing the role of mast cells and how they contribute to inflammation and symptoms within the body. My perspective has been that mast cell activation is really not the core issue, but a response, again, to an underlying trigger or issue. And while we may need to do something to kind of calm the systems, stabilize the mast cells, the real focus should continue to be on those underlying triggers and addressing those simultaneously. So I'm curious how you see mast cell activation fitting into this whole discussion on POTS.
Well, I think that's good thinking, Scott. And this may open up a whole can of worms. Let me approach this carefully. And it's something I discuss in the book and on the blog if any others are interested. But if you have a diagnosis of mast cell activation, some call it MCAS, we first need to evaluate it to be sure the label is correct. Here we are back at labels again. Have you been tested? Is your tryptase high, especially after an episode? Do you have true anaphylaxis? Tryptase is a chemical released by mast cells, but not by other inflammatory cells, basically. If tryptase is not high, we shouldn't assume mast cells are your only or even your main problem. Your mast cells can get caught up for many reasons, or it could be something that mimics MCAS. And many disorders can mimic it, and many inflammatory cells can be involved that can present in similar ways. Unfortunately, many people assume they have mast cell activation even in the face of negative testing. And I think mast cell activation is terribly overdiagnosed. I get it. I did the same thing at first. At first, like many others, I was all over mast cells. It sounded like we had those issues. The symptoms fit. It must be right. What clued me in was the negative tryptase in most everyone in the invisible illness community. Remember, I had this outreach with prettyill.com, that blog. So people sent me their tryptase levels from around the world. The vast majority were negative. But when I heard that mast cells must be activating and releasing some chemicals, but maybe not tryptase, I thought, it just doesn't sound plausible. Maybe we jumped the gun with mast cell activation in most cases. And again, we need to keep our thinking caps on. My question is, if your mast cells are indeed activated, what activated them and what cells have they activated? But super important, are you sure mast cells are the main problem? We consider about 50 conditions that can mimic mast cell activation. I don't think most doctors are willing to dig that deeply into individual cases. It's just so much work. It can be easier to treat everyone the same way and just hope for the best. I think that's a mistake. If testing is negative, we need to keep thinking.
Do you find that specific interventions for mast cell stabilization, antihistamines, those types of things, do they seem to lead to improvements in symptoms in people with POTS?
Yeah, again, we want to dig into each case versus a truly mast cell activation, right? I will tell you that if antihistamines help, there's likely too much histamine in the body, but where is it coming from? Right? A positive response to antihistamines doesn't mean the patient has mast cell activation. Even high levels of histamine or prostaglandins in the blood do not mean it's a mast cell problem, because a lot of inflammatory cells kick out those chemicals. We've got to be smarter when we're trying to analyze this. But if histamine is high, it can absolutely help POTS patients to block some of it, because histamine causes vasodilation. So it can worsen POTS symptoms. It's not a cure, but it helps. And stabilizers, like you mentioned, can also help some POTS patients. But a good response to a stabilizer, like cromolyn, sodium, doesn't mean the patient has mast cell activation. Stabilizers calm down other inflammatory cells too, like eosinophils, basophils. Rarely does one inflammatory cell predominate in an inflammation, because inflammation is a cascade. One cell releases cytokines that cause other cells to become involved, which causes other cells to become involved, etc. The inflammatory cascade is quite complex, and if we don't keep all aspects of inflammation in mind, we risk remaining ill.
So we've talked about POTS, we've talked about your personal journey with Ehlers-Danlos, we've talked about mast cell activation. Now I'm excited to get to the vagus nerve. And I think this might be one of the first shows that we've talked about the vagus nerve. And so also another area that I'm really excited to learn more about. So talk to us a little bit about what is the vagus nerve? What does it do for us? Maybe a little bit around the primary structures of the vagus nerve, the role that it plays in POTS and gastroparesis and those types of conditions.
Okay. Well, the vagus nerve is the longest cranial nerve in the body. And although we speak of it as one nerve, there are actually two of them, of course, one on each side of the neck. The vagus nerve is part of the parasympathetic nervous system, the rest and digest system of the body. So after something scares you, like a bear, for example, which activates the sympathetic nervous system, your heart races, your breathing rate increases, you can become flooded with chemicals like adrenaline, and you can run. That's a great thing. But when the bear is gone, it's the parasympathetic nervous system that allows your heart and breathing to normalize, your body to calm down, your digestive organs to work again. And the two systems of the body have opposite effects, and the balance between them is critical. So as part of the parasympathetic nervous system, the vagus nerve specifically slows your heart and breathing. It also allows most every digestive function, from swallowing to opening up the pyloric valve at the base of the stomach so food can exit. It tells your stomach to start making more stomach acid when it's appropriate. It signals the gallbladder to release bile. It partially controls the pancreas to release digestive enzymes, and it controls peristalsis through the intestines, motility, if you will, so you can have normal bowel movements. Interestingly, it also helps us control inflammation. And this was not my work, but Dr. Kevin Tracy figured out that the vagus nerve is the anti-inflammatory nerve of the body. The vagus nerve controls a lot. And I began to suspect it as a problem in my own case because my gut symptoms and fast heart rate began at about the same time. When something like that happens, you have to ask, what could affect both of these things at the same time, right?
Talk to us a little bit about the things that can damage the vagus nerve, and how can we tell if we actually have a nerve problem with the vagus nerve?
Yeah, well, because the vagus nerve is so long, it goes from the brain down the neck into the chest and the abdomen. It has a lot of opportunities to get damaged, things like heart ablation, most abdominal surgeries, gastric sleeve, other stomach surgeries, all have potential to damage the vagus nerve. Neck injuries and other bodily trauma can also damage it. If you have a damaged nerve, symptoms occur based on the location of the damage. So the higher up the damage, the more problems you see. If the damage is very high, you can even have problems swallowing or speech problems. Further down, your heart rate may speed up. You can have constipation, poor digestion, and then malabsorption because your stomach acid, bile, digestive enzyme function is all down. And even gastroparesis, delayed gastric emptying, among other things.
Yeah, it sounds like it's tied to so many issues that people with chronic illness deal with. We'll talk a little bit about SIBO potentially. We'll talk about gastroparesis. In fact, let's talk about gastroparesis now. So you talked a little about your personal story. You mentioned earlier that you experienced gastroparesis as well. So how did you connect the dots with your specific gastroparesis to the vagus nerve? And then talk to us about how that impacted your ability to have a bowel movement. I remember that was a significant issue for you in your story. And then a little bit about the role of acetylcholine in vagus nerve dysfunction.
Oh boy, okay. This is quite a story. This is kind of the story of how a patient figures out what the doctors are missing, right? Kind of reminds me of the joke, why does the rabbit outrun the fox? Because the fox is racing for his dinner and the rabbit is racing for his life. I was the rabbit. I was desperate for answers. I wasn't getting help from any of my doctors, the foxes, but the doctors didn't have to live with me 24/7, and they didn't have to see the suffering, and they didn't have to endure it. My motivation for answers was rightfully so stronger than theirs. I was suffering. You see, my constipation had gotten so bad, Scott, that I ended up with complete gastroparesis. Nothing was moving. And it had been like that for 11 days. And I had tried everything, no result. I went to my primary care doctor and she wasn't able to offer anything I hadn't already tried. I did tell her that I was having some dull pain in my lower right hand abdominal area. So out of desperation, I just don't think she had any idea what to do. She sent me to a urologist to see if maybe I had a weird kidney stone. And the urologist was super nice and really smart. And I told him I was considering the possibility that my gastroparesis was due to vagus nerve damage. And at the time, I was thinking maybe it was compressed at my neck. I asked him if the pain in my abdomen could maybe be a bad ileocecal valve, the valve between the large and small intestine. Well, he gave me some of that nasty dye to drink and imaged me for kidney stones, and I got the all clear. He thought it was a brilliant idea about the ileocecal valve, though. So he sent me to a surgeon to see what the surgeon thought about the valve. And I remember the surgeon said, Diana, if you're afraid your vagus nerve is defective for any reason, don't have abdominal surgery unless it's life-threatening. We cut right through that nerve. We cause gastroparesis. And I appreciated his honesty, but I left there with no answers and no bowel movement. stay with me here. There's a point to all this. I ended up going to the emergency room. I was looking at about 2 weeks with no bowel movement at that point. Well, that combined with being so sick, it was just too much. And they gave me a prokinetic, Reglan, and it did nothing. Then something amazing happened. I got a kidney stone. I called the urologist and said, I understand I didn't have a kidney stone 3 days ago, but I do now. So he met me at the hospital, removed the stone, and when I woke up, he was like right here, and he said, Diana, you were right. It's your ileocecal valve. I said, how do you know? He said, well, that dye I gave you 3 days ago, it's still in there, but it's all crammed up against the valve. I thought, great, we know what's wrong. What do I do? I have no idea. So I went home, and I'm there all alone with no help. I had no idea of where to turn next. As patients, that's kind of where we're often left, right? Nowhere to turn, no answers. It's not a good feeling. So I laid there and I thought, I'm on my own here. I'll do the only thing I know to do. Let's just assume I'm right. Let's just say this is the vagus nerve problem. I had no idea if the nerve was compressed, but I was going to assume it wasn't working. What could I do? So I thought about the anatomy I learned. Scott, it was like 35 years before that. Weird. I know that I remember that. And I thought about the structure of the nerve. I remembered there were 2 parts to the nerve. There's the long preganglionic portion that goes from the brain all the way down to the organs. And there's a gap, or a little synapse, I call it. Then there's a tiny postganglionic nerve that communicates with the organ. I remember the professor saying, the postganglionic nerve is so small, it's almost a part of the organ itself. Again, so weird that I remember this out of the lecture. Now, nerves communicate with a chemical that jumps across the synapse. There's no direct connection between the 2 parts of the nerve, nor the nerve and the organ. There's release of a chemical or neurotransmitter that jumps across, lands on a receptor. I thought, if my preganglionic nerve is defunct, I should still have a postganglionic nerve, right? I haven't had abdominal surgery, luckily. It should still be there. So I thought I'd introduce the neurotransmitter artificially to see if I could get the postganglionic nerve to respond. And the neurotransmitter for the vagus nerve is acetylcholine, but that's not an injectable drug. The body breaks it down immediately, which is why there's no blood test for this. Instead, you have to use an imitator of the neurotransmitter, what we call an agonist. I asked myself, okay, what's the agonist for acetylcholine at the vagus nerve? Well, that was easy. The vagus nerve is the only nicotinic acetylcholinergic nerve in the body. We use that term because its agonist is nicotine. So I called my husband at the office and asked him to bring home a nicotine patch from the drugstore on his way home. His response was like, what are you up to now? He was really used to me running some experiments on my body. But I told him I'll explain it later. I put the patch on my lower right-hand abdominal area. I didn't know if it mattered where I put it, but I imagined the nicotine kind of going through the skin and landing on that postganglionic vagus nerve's receptor. And I hope for the best. Well, about an hour and a half later, things started to move. The valve opened. I had a normal bowel movement. I thought, what? I used that patch every day for 4 days. It worked every time. So I called a few people with gastroparesis POTS and asked them, do you want to try something? Am I going crazy? It worked for them too. I had to stop using nicotine though because it activates inflammation. My stomach looked like it had been attacked by fire ants. I was miserable. But the experiment taught me 2 things. And one, I didn't have some rare autoimmune disorder affecting the receptor. My receptor worked fine. It just wasn't getting the signal. All the research into POTS at that point revolved around autoimmunity. And I knew that likely that wasn't correct for most of us. So instead, we turned all the research at genetic disease investigators elsewhere. We went away from autoimmunity. 2, it told me that either I had a defunct preganglionic vagus nerve or I had a neurotransmitter problem. And that was the next puzzle.
So let's talk a little more about acetylcholine then. So the role that it played for you obviously was profound. How can one differentiate between an acetylcholine issue and a problem with the nerve itself? And then when people do have vagus nerve dysfunction, how often do we suspect that's related to this neurotransmitter?
Yeah, that's a great question, Scott. And this is tricky. Yet the answer is important because it could help us figure out our true underlying problems, right, in each case, and keep us from chasing some ineffective treatments too. What I did over almost 5 years was I collected symptom spreadsheets from hundreds of people with chronic fatigue syndrome, one category, EDS-POTS, another, fibromyalgia, and PTSD. That might sound odd, but autonomic dysfunction isn't uncommon in PTSD. Well, within those spreadsheets, I scattered about 35 symptoms, excuse me, including such things as constipation, gastroparesis, dry eyes, tachycardia, fatigue, brain fog, large pupils, visual snow, orthostatic hypotension. I gathered these for almost 5 years and found that the majority of patients with these invisible illnesses had the majority of these 35 symptoms. These symptoms would often come and go, but there was a pattern there and it was clear. The 35 symptoms that I included were those of anticholinergic poisoning. Most of us had such low levels of acetylcholine release that it was as if we'd been poisoned with an anticholinergic drug, although we hadn't actually been poisoned. For the majority of patients, the reason for the vagus nerve dysfunction was not a problem with the vagus nerve after all. This was a problem with the neurotransmitter acetylcholine, and you could tell from the symptoms. If you look at the symptoms of anticholinergic poisoning and ultimately response to treatment to see the difference, it was really validating to me, Scott, because I often told my doctors, it feels like I've been poisoned. But I also told them it felt like I'd been electrocuted, so I don't think that meant much to them. But it makes so much more sense when you see how acetylcholine involves more than just the vagus nerve and the autonomic nervous system. It's also important for the brain, the central nervous system. It allows us to make short-term memories, organize our thoughts, what we call executive function. It helps us stay mentally alert. In my illness, I got so bad that I was only awake about 3 hours a day. Those 3 hours, it was difficult to stay awake. I was getting worse. I couldn't make a to-do list of even 3 things. If I wrote down 1 or 2 things, I was so mentally exhausted, I'd sleep for 7 hours. But acetylcholine is also used by the peripheral nervous system, your muscles. In my case, I was so far beyond fatigue. I told my husband I had trouble just lifting my arms sometimes. My neurologist assumed I had some neurodegenerative condition. I certainly presented that way. But acetylcholine is a critical neurotransmitter, and you don't need to be as sick as I was to see the clues and improve your levels and benefit from it.
Is there a correlation between specific genes and the production of this neurotransmitter acetylcholine? And if so, how does that potentially change the way treatments might be approached?
Yeah, I'm so glad you asked that because that's certainly what I was thinking at the time. I was thinking we had genetic problems. That's how my whole family ended up sick, etc. So when I figured out that for most people, this wasn't a vagus nerve problem after all, it was an acetylcholine problem, my first thought was like yours. It was a genetic defect in making acetylcholine, right? So at that time, I was on a mission to try to find some oral mix of supplements that could come into the body at once and come together to stimulate that postganglionic vagus nerve, just like nicotine did, but without the inflammation that the nicotine causes. If this was a genetic issue in making acetylcholine, I wanted to find workarounds. So I looked at 2 main genetic defects pretty deeply. Now, to understand the defects, you have to understand how the body makes acetylcholine, which is basically an acetyl molecule and a choline molecule, right? One gene I studied means that the affected person needs more choline than other people. It's called the MTHFR1 gene. It's not the MTHFR gene, just saying. If you don't get enough choline, you can develop liver problems and other issues. But my concern was that if your choline levels are low, perhaps you could have trouble making enough acetylcholine. Choline doesn't cross the blood-brain barrier and it's super bulky. So I had to be more clever in the workaround than just to add choline, right? But the other genetic defect is the CHAT gene, C-H-A-T. You see, the body gets an acetyl molecule by breaking off an acetyl group from acetyl-CoA. It does so with an enzyme. If you have a defect in this gene, you can't get your acetyl group that way. I had to figure out another pathway using a different enzyme so these folks could get their acetyl group from a different molecule. The workarounds are great, and they work fine. And I built it right into a supplement mix. I guess we'll talk about that eventually.
Yeah.
We call that ParaSym Plus. But when I was working on this blend of ingredients to boost acetylcholine, I wanted to cover all of us for genetic defects in the pathway. I included all the workarounds. I didn't know if my kids or I dealt with those defects at that time. I didn't want others to have to know their genes to be sure it would help them. But in the end, the genetic defects affected about 1 in 50 patients, more than the average of 1 in 500, but it wasn't the majority still. There was still work to do.
Let's talk a little more about the ileocecal valve and the role that that plays in gastroparesis. So talk to us about the sphincter of Oddi, that's connection to the vagus nerve and to the discussion around POTS.
Yeah, sphincter of Oddi or Odi or tomato. But the sphincter of Oddi or Odi doesn't get enough attention, I think. It's the sphincter that both bile from the gallbladder and digestive enzymes from the pancreas allows to be released. When that's not working well, the bile and digestive enzymes can back up and cause a lot of problems. I remember a lecture I heard on EDS patients years ago, how commonly they had sphincter of Odi or Oddi problems. It was a mystery at the time because that sphincter shouldn't be affected by a connective tissue problem, right? The sphincter is controlled to some degree by the vagus nerve, which is, of course, allowed to work by the grace of acetylcholine. So if a patient seems to have recurrent pancreatitis, is what we kind of look for this, that sphincter needs to be considered. If the sphincter's not working well because of problems with acetylcholine, well, we've got something for that, right?
Let's talk a little about the gallbladder. So it's not uncommon that people with various chronic conditions end up having their gallbladder removed. When is it helpful? When is it harmful? And how can we be sure that we really need to consider removing the gallbladder?
Yeah. Well, let me see if I can answer your question with my own gallbladder story. Unlike many of others, I had a fair amount of gut pain. No one really understood it. I had every GI symptom there was. So the doctors performed a HIDA scan and found my gallbladder wasn't working. My ejection fraction was pitiful, 8%. So they wanted me to remove my gallbladder. And I think that's not uncommon, right? I was trying to think it through. And I asked if the gallbladder was maybe filled with gallstones. And said, no stones. Okay. Is it infected? Is it about to burst like an appendix? No, looks fine. Okay. Is the opening maybe stuck closed? No, they could see the opening. It was wide open, no problem. Okay, well, first, it didn't seem urgent. And second, I wanted some time to think it through. I told them it sounded neurological to me. It sounded like the gland was just sitting there happily, waiting to get a signal. So I said no to the surgery. And luckily, I saved my gallbladder when I put together those pieces of the acetylcholine problems and began taking what we now call ParaSym Plus, which is great. We can live without a gallbladder. People do it all the time. But life is a bit easier with one, and I find that life is usually better with a little bit of cheese on top. So it's not so much that the surgery is harmful, although I know no surgery is risk-free. The question is it necessary? So I would say if your gallbladder isn't working well and you don't have some urgent need for it, like gallstones, you can pause, maybe with your doctor's okay, and consider if your problem could be neurological, because we have something to work around that. Although it's been missed for many, many chronic illness patients, hence how we got a patent. I often wonder how many people have similar issues without becoming necessarily as sick as I did or bedridden. And even in the normal population, how many people blame brain fog, constipation, fatigue, gallbladder problems, well, I'm getting older, I'm under a lot of stress. So I'm a big believer in being proactive.
And it's interesting how fast conventional medicine is to remove the gallbladder. I mean, I personally think it is important. Can we live without it? Sure. But in terms of assimilating and breaking down fats, including, fatty acids, in terms of detoxification and moving the bile through the system, I mean, there are certainly important things. So there's obviously going to be those emergency cases where someone has to do it. But I like what you're suggesting, which is, well, let's look at whether that's really necessary or not. In some cases, maybe it's not necessary.
Right.
Let's talk about the gastroparesis again. Gastroparesis and other gut symptoms, you mentioned quite a few of them that you experienced in POTS. So is that related to the dysautonomia and the nervous system not functioning properly? Do POTS patients have higher rates of SIBO because they're not able to move food through the digestive tract and not having that migrating motor complex that's working correctly? What is the connection between gastroparesis, POTS, and SIBO?
I'm so glad you mentioned SIBO. We see a ton of it at POTS care. I certainly went through it. What I found with these patients, the idiopathic POTS patients, let me make that clear, is that the majority of the gastroparesis patients are suffering with deficiencies in acetylcholine. It can be tricky to recognize because there's no blood test for it, of course. Acetylcholine breaks down immediately, so even when someone suffers with anticholinergic poisoning by drinking a bottle of atropine, for example, which is not us, right? Doctors have to recognize it based on presentations. Patients will present in the ER with large pupils, constipation, tachycardia, crazy moods, flushing, etc. In the history, it becomes clear the patient has anticholinergic poisoning and they begin treatment. Usually they start with Xanax to calm down the sympathetic nervous system, overriding it. But our patients have not been poisoned. The symptoms can come and go a bit easier or less pronounced, and they may be on medication that can mask some of the symptoms too. And they don't go further into seizures, coma, and death, which makes it harder to diagnose. But they've been suffering with them for a while. The abnormal bowel function starts to take its toll after a while, and SIBO is a common problem. But think about it. If the vagus nerve controls movement of the stool and in the GI tract and allows you to have normal bowel movements, the nerve also tells the stomach when to boost stomach acid, which helps break down your food properly and kill some nasty germs that can sneak into the food. And then the gallbladder and pancreas also allow a normal breakdown of the food, which is required for nutrient absorption. And often the constipation or gastroparesis or delayed gastric emptying allows food or stool to just sit there. Not good. When the system fails us, we develop dysbiosis where the balance of good and bad bacteria, candida, etc. is gone. SIBO is a common result. What I found, though, is that we return the function of the vagus nerve with boost acetylcholine. If it's not getting released, normalcy starts to return. And SIBO can generally resolve by itself. And in many patients, less is more. Antibiotics for SIBO can be rough, and I've seen it set back patients for many months. But if we normalize the vagus nerve function, the body likes to take care of it in the most natural way possible, and oftentimes can. The research I was just going to mention showed that most gastroparesis in POTS is not an autoimmune problem with the receptors, right? But it's a problem with acetylcholine, the neurotransmitter needed by the vagus nerve. When acetylcholine levels are low and the vagus nerve doesn't work well, SIBO is just one of the problems that results. The test of the postganglionic vagus nerve with that agonist of the neurotransmitter basically proved the nerve was fine. The receptor is fine. Although it appears much like the type of nerve problem you'd see in autoimmune autonomic gangliopathy or ALS or Parkinson's, but thankfully it's not. It's a neurotransmitter problem.
Yeah, and coming back to your comment on antibiotics for SIBO, it's interesting because it seems that they often do help symptomatically, and yet almost always when they stop the antibiotic, the symptoms then return. So It's not the long-term solution. And I like the kinds of solutions that you're talking about here, which is, okay, well, let's look more at what's the potential root cause and looking at the vagus nerve and looking at supporting the migrating motor complex and dealing with kind of things moving through as it should move through the system.
Right, normalcy, right?
Yeah, absolutely. Talk to us a little bit about Mestinon and how does that potentially help people with POTS?
Right. Because to understand how mestinon can help and what its limitations are, you have to know a little bit about the synapse, that gap in the vagus nerve. You see, acetylcholine is released into the synapse, right? Lands on the receptor and there's a response. Then the nerve releases acetylcholinesterase. It's an enzyme that breaks down the acetylcholine so it doesn't continue to make the receptor fire, right? If we block acetylcholinesterase, acetylcholine levels go up a bit in the synapse. Mestinon is an acetylcholinesterase inhibitor to help boost acetylcholine and can help gastroparesis and can oftentimes help POTS. But here's where it fails. Mestinon does not provide the building blocks to make acetylcholine. It only preserves what is released. It cannot cross the blood-brain barrier to help boost acetylcholine for the brain. Remember that brain fog that occurs? It doesn't help with that. It can't work around any genetic defects in the production of acetylcholine. If you're not producing enough acetylcholine, anticholinesterase to preserve what you do produce is not sufficient. You also can't make enough acetylcholine if you get low in certain nutrients like thiamine. Mestinon doesn't help with those potential deficits. So ParaSym Plus, as we'll talk about, I put everything in there to cover for us. We don't have to know our genes. There are workarounds for everything. It contains an acetylcholinesterase inhibitor like mestinon. But unlike mestinon, the ingredients cross the blood-brain barrier to boost cognition. It's so important. It also will help the lacrimal nerve to help stimulate tear production. This was interesting because the lacrimal nerve also uses acetylcholine. Mestinon can't help with that. But have you noticed, Scott, there's a fair number of dry eyes out there? Mm-hmm. There's no drug that will do all of this, including mestinon. It's one reason I got a patent, or I guess 2 patents now. The discovery was unique. No one had put all this science together before, which is one reason so many of us were suffering, including me.
So a couple of questions before, and I do want to get to those products because I'm actually personally very interested in learning more about them and how they potentially will help people. With this understanding from our discussion of the importance of the vagus nerve functioning well, there are many other things that people explore in this realm as well. So I'm curious, have you seen vagal nerve stimulators, gargling, coffee enemas, frequency-specific microcurrent, polyvagal theory? Have any of those things been interventions that you found fairly consistently helpful for your patients?
Yeah, it's a good question because it sounds like stimulating the vagus nerve would help us, right? Well, remember, it's not really a vagus nerve problem. For the majority of patients, it's an acetylcholine problem. I remember having such abnormal stool and so much candida. I was wondering if I'd need a fecal transplant, but I was able to stay in traditional medicine, get gut function and stool normalized. When you have good stool, it's worth its weight in gold, Scott. I was hesitant to do something like a coffee enema because it makes you have to basically start over with making good stool. I didn't need anything to stimulate the vagus nerve because remember, it wasn't a vagus nerve problem. The nerve is fine. It was an acetylcholine problem. It changes your thinking.
Yeah, absolutely.
Sure. It was a game changer for my kids and I. That's why my son stopped absorbing nutrients and why he developed severe osteoporosis. I remember being in my kitchen using my organic chemistry knowledge, which was ancient, to try to put all this together. Thank heavens it worked. But in most patients, this is a medical illness. It needs to be identified as much as possible and treated. I remember when I was sick, someone suggested that perhaps I needed to meditate. And I told them that would be a teaspoon of help against an ocean of problems. If someone would help me with the ocean, I would do my part with the teaspoon. For many people, if they have a medical illness, first, that needs to be addressed. Otherwise, it's just this uphill battle to work through it by addressing the psyche or using all the other techniques.
Right.
Those can help, but they're often insufficient for relief. If the medical issue is not identified and treated, symptoms usually just keep increasing, they evolve, and worse, the patient can feel guilty. It's as if it's all their fault. The tendency is to put the blame on the patient. But I see doctors do that if they can't figure out a patient's case. It's a terrible error. Patients deal with enough and shouldn't also have to carry the weight of guilt for not handling their condition very well.
One of the other concepts that I got from listening to some of your prior interviews was the idea of sympathetic versus parasympathetic tone. And many of us think of sympathetic dominance of the nervous system and think about things to kind of quiet the sympathetic side of the nervous system, where it sounds like what you're suggesting is what we really need to focus on more is not so much reducing sympathetic tone, but more increasing parasympathetic tone. So what are some of the tools that can help us with tonifying the parasympathetic nervous system?
Yeah. Well, it's a tough one to answer, Scott, because patients are not all alike, right? And there's always an underlying medical cause when you get that sick. But there is an imbalance between sympathetic and parasympathetic nervous system. It helps us to survive in that case by calming the sympathetic nervous system. When I was flooded with adrenaline, the norepinephrine, I ate Xanax like it was Pez candy. But I was so flooded, there is no way I could calm down my body by meditating or finding my happy place. It was a medical problem. But my son didn't exhibit in that way at all. My daughter had more swings than either of us, so I hesitate to make too many generalities. We have to evaluate each case individually to identify what's going on. There are many, many layers to every patient's condition. But I will tell you that when patients walk into our office with huge pupils, or oftentimes they're wearing sunglasses even indoors, we know they're miserable. It's so hard to live with that sympathetic nervous system so overriding the parasympathetic. Pupil size is one objective measure of the balance between the sympathetic and the parasympathetic nervous system. We have to look at both systems to figure out what to do. In my case, the doctors were totally focused on lowering the sympathetic nervous system, but no one ever thought that perhaps my parasympathetic nervous system needed a boost. That set me back for many years.
So let's talk about some of these cool products that you've created. I'm excited to learn about them. So you've got some nutritional supplement products that can be very helpful for people in this realm. If people want to follow along as we're talking, the website vagusnervesupport.com is where you can learn more about these. So let's start with the patented product, the ParaSym Plus. How is that supporting the vagus nerve? Some of this we've touched on, but how is that supporting the vagus nerve issues in POTS? What are some of the key issues or symptoms that people report improving with ParaSym Plus?
What I think is important to remember is that ParaSym Plus supports acetylcholine levels, of course, which are needed by the vagus nerve, both afferent and efferent fibers to and from the gut and the brain. Remember that most patients do not have a vagus nerve problem per se, but they have a neurotransmitter problem, right? Also, please know that if you do have a damaged vagus nerve, ParaSym Plus will work around that by stimulating either the postganglionic vagus nerve or the receptor on the organ itself. But the symptoms we look for are fairly straightforward. These are the same symptoms as anticholinergic poisoning, but turn it down a notch because patients haven't actually been poisoned. I think that's one reason that I was able to put this together. Honestly, I'm an eye doctor, and eye doctors use anticholinergic drugs every day. You know, those eye drops that your eye doctor uses to dilate your pupils? That's an anticholinergic. Eye doctors know the pharmacology well, are trained to recognize anticholinergic poisoning. Some of the symptoms are weird visual symptoms too. I remember some people reaching out to me saying they saw spiders or parasites in their vision, or that seeing textured surfaces bothered them. And at first, I had no idea what they were talking about, Scott. But when I heard the complaint of visual snow a few times, it finally clicked. Those are symptoms of anticholinergic syndrome. So if you turn it down a bit, you keep an eye out for brain fog, large pupils, flushing, dry eyes, constipation, or even gastroparesis, fatigue, especially mental fatigue, poor gallbladder function, sphincter of Oddi dysfunction or Oddi, tachycardia, orthostatic hypotension, mood swings, lousy digestion, ultimately dysbiosis, including SIBO. And these are some of the symptoms we can see resolving over time. Some of us have subtle symptoms that come and go, and some of us can ultimately end up with them all and then suffer with nutrient deficiencies and all that entails, as well as fairly dramatic changes in our personality. I know, I was there. I even got to the point of hallucinating. It got so bad, it was miserable.
So we've talked about SIBO, the migrating motor complex. It sounds like ParaSym Plus, through its support of this neurotransmitter issue, can be potentially helpful there. We've talked about inflammation, whether that's histamine driven or otherwise. Talk to us a little bit about how ParaSym Plus potentially helps with reducing inflammation in the body.
Yeah. Well, again, everyone is different, Scott. I wish it was so easy we could all be treated the same, but it isn't the case. I would mention that if you have a diagnosis of mast cell activation syndrome, don't let your doctor stop thinking if your testing is negative. But if you have inflammation due to mast cells, histamine, or not, and you're trying to control abnormal inflammation, you need your parasympathetic nervous system in top condition. Someone else figured that out, right? ParaSym Plus supports the parasympathetic nervous system. That's how it helps with inflammation.
Other common complaints in Lyme and mold and related conditions are things like brain fog and anxiety. How might this product be helpful for those types of symptoms?
Right. I think complaints of brain fog and anxiety are super common in all the invisible illness patients from what I've seen, including PODS, chronic fatigue syndrome, Lyme disease, mold, fibromyalgia, and PTSD. When working on ParaSym Plus, one of the goals I had was that it had to cross the blood-brain barrier to boost acetylcholine for the brain. It does so very well. In my own illness, I got to the point where I had zero short-term memory. They tested both my IQ and my short-term memory when I applied for disability. I had none. I couldn't stay awake. I couldn't keep my thoughts together enough to write those 3 things down to do. When I first started what we now call ParaSym Plus, that very first day, I could feel my brain start to work again. I was able to think for about an hour and a half and actually work. And then that same mental fatigue started, and I thought, I need to go to bed. I thought, wait, could I need more? Yes. So I took some more. I could think again for another hour and a half or so, and it was gone again. My first day, I took 5 doses. You don't need to be as sick as I was to benefit. Do you know that? But the worse it is, the more dramatic the response. It's something I never go without.
You mentioned earlier in the show that there really is not an effective blood test for looking at acetylcholine levels, but is there any of the neurotransmitter testing? Is there any way to confirm low levels of acetylcholine and then see those improve as people implement a product or tool like this?
Yeah, there is no objective test of it. ER physicians are trained to recognize it on presentation. They're mnemonics so they can remember those symptoms too. There is no objective marker. We do look at response to treatment, and that's usually sufficient to do it. The sicker you are, the more immediate the response. Even in the cognition problems, we'll have patients they can hardly stay awake. They're just sinking in the chair. 15, 20 minutes, you can see the sparkle back in their eye. They're paying attention and focused. You can actually feel it. If you're not quite as bad, it can take longer, or it can be more subtle than that. But the sicker you are, the more dramatic it is. I wish there was an objective test for it. I really do. Then it'd be easy to prove, but you can't.
A couple of the other products that you have that are relevant to the topic that we're talking about today. So talk to us a little about the digestive enzyme product, what's unique about it, and how does it potentially promote the balance of bacteria in the small intestine and also of candida or candida in the body overall?
Yeah, some supplemental digestive enzymes can be important, especially just getting started with something like ParaSym Plus, or on folks who did have their gallbladders removed or what have you. But I had to create digestive enzymes because I couldn't find on the market what I needed personally, nor what most very sensitive patients needed to boost digestive enzymes. Oftentimes, we think the more ingredients, the better. But in this case, less was more. Protease, for example, helps digest protein, very important, but it's very irritating to the stomach line, very inflammatory. It's in peer-reviewed literature. I didn't want too much protease. Some ingredients commonly included in digestive enzymes work against us. A common prebiotic is sometimes added, and it sounds like that'd be great for us, right? A prebiotic, not so much. Inulin, the most common prebiotic, is one of the FODMAPs, the bloating kind of discomfort, GI problem ingredients. And then one of my pet peeves is when I see cellulase in a digestive enzyme. Cellulase breaks down cellulose. That sounds like we should have it, but humans don't make cellulose. We depend upon undigested cellulose to help our stool stay soft. It's fiber for us, right? Promotes normal motility. Termites produce cellulase, and cows do too, but they have a separate stomach for that. Humans are not meant to have cellulase. So one of my mottos is to stay in the science. These digestive enzymes are unique. I just couldn't find a combination that worked for me until then.
And then you have what you call the soothing digestive aid. And so that's interesting because that appears to potentially help those with various types of dysbiosis, encouraging motility, as we talked about, supporting small intestinal bacterial balance. What kind of feedback do you get from people using the digestive aid? And do you see that as a tool that potentially could be helpful for people dealing with SIBO? Because it's just such a common issue.
Yes, it is. Soothing Digestive Aid, it's an amazing product. It has 2 carefully chosen ingredients. One is apple cider vinegar, which is an acid that can help you boost your stomach's acidity to promote digestion. When our vagus nerves are sluggish, or if we're on acid reducers, Zantac, Prilosec, and such, we often need a boost in stomach acid production when we eat. We just don't want the acid when we're not eating, right? But most apple cider vinegar capsules are not acidic enough to be effective. This one's at a very high concentration level, so it can actually help you. It's hard to find. It's more expensive than most concentrations, but it's necessary to actually boost stomach acidity properly. Good stomach pH is one of the first steps in preventing that dysbiosis or SIBO. I should mention, you don't want to drink apple cider vinegar because it is acidic, and acid is not meant to go down the esophagus continuously, especially in those of us with inflammation. Many inflammatory cells can get activated when acid passes over the esophagus, so we need for this to be in a capsule so it opens up in the stomach. It also contains high-quality ginger, which is very soothing to the digestive tract, promotes motility, and helps reduce nausea. Combination is great. I love it. I hear over and over how it's helpful for so many.
One of the other things that I read was that you've actually done some trials with these products as well. So any comments you'd like to share with listeners about the trials?
Yes. In fact, there's a white paper with some of the research on our website, the results of that 5-year symptoms checklist and the first trial with ParaSym Plus. We ran 2 other in-house trials with ParaSym Plus. In the last one, we thought if we have to take this every morning, it'd be great to put it in a breakfast bar or a smoothie or something, right? That didn't work. By work, I mean we didn't see a bowel movement as a response. Since we can't measure acetylcholine levels, right? I looked for a bowel movement to be sure that everything came together quickly enough to stimulate that postganglionic vagus nerve or the receptor, much like nicotine, but without the inflammation. So we recommend that you take 2 to 3 capsules on a basically empty stomach first thing in the morning for the best results. And I'm happy to say just last week, I received a second patent for ParaSym Plus. This one is for dry eyes. During those studies we did, we were so focused on the gut and the cognition. It wasn't until the end of the studies, about 4 to 6 weeks, that we realized the dry eyes were gone. It made perfect sense, but then we were able to turn our focus to the dry eyes. And I know we're talking about the invisible illness world, but you don't have to be ill like we were to suffer with some of these conditions, dry eyes included. We're talking about quality of life, and there's a lot getting missed.
One of the things I like about your company as well is there's very few companies that offer a money-back guarantee on their products. And I know that you guys have a 30-day money-back guarantee as well. So to me, that says a lot when companies are willing to do that. So as we wrap up our conversation today with everything that you've learned about POTS, Ehlers-Danlos, mast cell activation, the vagus nerve, how much do you think we still have to learn? And is POTS curable, or is it something that most people will need to manage over their lifetime?
Yeah, I love this question. Do you know there's a lot that goes on behind the scenes in research you don't necessarily know about until it's released, but you can be confident work is being done. Now, is POTS curable? You can absolutely recover from POTS. My case and that of my kids stand as evidence of that, as do many of the patients who come to POTS care. strictly speaking, POTS is a problem with orthostatic tachycardia can absolutely go away. I would have never set up POTS care if that wasn't the case. One, I would have been too sick. And two, I would have never want to work somewhere where patients never recover. That'd be terrible. But I will tell you that many of us have things we manage in our health to keep us from developing POTS again. An important part of what we do at the clinic is to teach patients what we're learning about their condition so that they can ultimately take control again. Different from most clinics, we don't want patients to have to keep coming back to us nor to be dependent upon us, because patients come from around the world. That isn't realistic anyway. So there's a lot of education going on in the clinic, but you bet you can recover.
Tell us a little bit about your book, The Driscoll Theory, and then how listeners can follow your work, how they potentially can work with you as a practitioner if they're interested.
Yeah. Well, when I was first sick, Scott, I started a blog. Does that sound familiar? prettyill.com. And it was really just an outreach to share with people, oh no, this is real and this is really bad. I share a lot of what my kids were going through and our symptoms. I never knew I would start to get answers that others had missed. But when I did, I put them out on that blog. I wrote a book. It's been almost a decade ago now, The Driscoll Theory, which focused on EDS and POTS. But honestly, it could have easily been written for chronic fatigue and some of these other invisible illnesses. The book is still available on prettyill.com, where there's also a forum. And I pop on this forum every week or so and try to answer as many questions as I can. And it's been going on for a decade. Although I still announce most things there, I'm now seeing patients full time, of course, at POTS Care. So my focus is turning to try to release what we're learning in peer review whenever possible to share more of what we've learned.
And are you taking new patients at POTS Care if people are dealing with POTS?
Yes, we are. And it is booking up. Word is spreading.
Excellent.
Yeah, it is great.
So my last question is the same question for every guest. What are some of the key things that you do on a daily basis in support of your own health?
Yes, because I do think I do have to support my health. I think many of us do. And health for many of us involves both physical and the psychological, of course. And for the medical, I've become an expert at my own body, what it takes to remain physically healthy. I'm so incredibly consistent with the supplements. That sounds so self-serving, I'm sorry. But when I stopped ParaSym Plus once, I didn't have fatigue anymore. I thought a couple of bowel movements a week is good enough. I developed pancreatitis. It started to reverse within a couple of days when I returned to ParaSym Plus. It is not something I take lightly. But I was also able to return to a good diet. I always preferred lots of fresh vegetables, salads, and heavier meals. But when I was sick, I had to eat sometimes whatever I felt I could keep down. I always do better if I don't eat too late. I try to watch that. But I don't have any more food restrictions, which is great. Beyond supplements and some medications, good eating habits, I had to have a bit of an attitude shift, Scott. This illness journey for me and my family was so incredibly tough. It would have been easy to be resentful of the entire process and come out of it scarred and mean, and also potentially had the power to destroy the relationships around me, friends and family alike. When you're sick for so long, you don't have much extra to give. It was often basically impossible to think much beyond my own little small bubble of illness and misery. With healing, though, I could begin to focus outward more, less on just survival and more on others. It's an important change to make, and letting go of some of the anger and resentment I had toward the doctors who couldn't help me was also very healing. I came to understand they did their best. Most of them did their best. They just didn't know. Had this illness resolved in just a few years, it wouldn't have been such a big deal. But 12 years, I had to make purposeful changes, like a gratitude journal. It sounds hokey, but it's really helpful. I try to get outside. I try to enjoy nature as much as possible. Always try to laugh every day, to take moments and pause and enjoy the good feelings when they happen. As cheesy as it sounds, these things really do make a big difference. When I was able to finally return to exercise, I began to, by walking most every day, try to make time to exercise. It's amazing to also enjoy my evenings after work doing something besides researching for answers. Sound familiar?
Absolutely.
Yeah.
Absolutely. Well, this has been super, super fun, learning a lot more about POTS and the vagus nerve in our conversation today. I appreciate you. I appreciate the hope that you give to people that are dealing with these conditions, the resources that you provide, the tools that you provide. And so thank you so, so much for being here today and just sharing your hopeful recovery journey with those of us that can really benefit from that encouragement and the example that you provide.
Do know there is always hope. I mean, at my age, as old as I am, if I could recover as sick as I was after 12 years, there is always hope. So don't ever give up. And I really appreciate your time, Scott. Thank you.
Thank you so much, Dr. Driscoll.
Thank you.
To learn more about today's guest, visit prettyill.com, potscare.com, or vagusnervesupport.com. That's prettyill.com, potscare.com, or vagusnervesupport.com. Thanks for your interest in today's show. If you'd like to follow me on Facebook or Twitter, you can find me there as Better Health Guy. To support the show, please visit betterhealthguy.com/donate. If you'd like to be added to my newsletter, visit betterhealthguy.com/newsletters. And this and other shows can be found on YouTube, iTunes, Google Play, Stitcher, and Spotify.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.